MS and bladder symptoms or lower urinary tract dysfunction are very common. About 80% of patients actually have lower urinary tract dysfunction that have MS. And not only do they have the dysfunction, it creates a considerable amount of bother for patients, probably falling just under fatigue and some of the other symptoms that we classically associate with a significant degree of bother. In terms of managing the symptoms, the first distinction is what's the underlying process. And bladder dysfunction with a neurologic cause can cause issues with storage of urine or how urine empties or how the bladder empties. Storage symptoms include frequency, urgency, nocturia, and even things like urgency incontinence or the compelling desire to urinate that a patient can't suppress that results in leaking urine. The emptying symptoms are the hesitancy, the slow urinary stream, etc. In order to make this distinction, there's a test, a post-void residual, that can be done in order to help determine if a patient is emptying their bladder or not. Some patients are unlucky enough to have both storage symptoms and emptying symptoms, but generally when we think of the treatments for bladder dysfunction, we want to say, is it a storage problem and we need to treat how the bladder stores urine, or is this an emptying problem and we need to deal with getting the bladder to empty more efficiently?
First, one needs to be sure that in fact the problem is due to their MS or a neurologic problem. And of course, patients who've had children may have pelvic floor problems and pelvic floor weakness. They may complain of incontinence when they cough or sneeze, and that would require very different management. Another common cause of these kind of symptoms is urinary infection. And in fact, patients who fail to empty their bladder with MS are more prone to urinary infection, but that might be a simple fix by treating the urinary tract infection with antibiotics. But if it's not one of those problems, some very simple testing, for example, testing the urinary residual volume, asking the patient to empty their bladder, and either with a catheter or with an ultrasound determining if there's significant leftover in the bladder, may help identify the rather less common group of patients who fail to empty their bladder.
In terms of the storage problems, we're often talking about medications called antimuscarinic medications that help relax or calm the bladder down. There are other medications such as botulinum toxin that can be used injecting into the bladder to help calm the bladder and improve frequency of urination, urgency incontinence episodes, etc. There are also newer investigational therapies and newer technologies that are sort of coming forward, but in terms of the medications that we have that have been tested in the MS population, I think antimuscarinics remain the mainstay of therapy. In terms of bladder emptying or issues with emptying, often we're relying on intermittent catheterization, indwelling catheters, and or urinary diversions. Unfortunately, not a lot of medications that we give patients actually help the bladder empty. And that makes it something that we have to deal with actually more of a mechanical apparatus to help empty the bladder.